Hello, this is a psoriatic arthritis treat to a target versus usual care randomized controlled trial. This is an investigator-initiated grant from Dr. Janet Pope. Amgen is the sponsor. JSS Research will be running the study. Background. We know that in rheumatoid arthritis, treating to a target allows for more patients to achieve the target than usual care. We don't know if this is the case in psoriatic arthritis. In addition, we don't know what the target should be in psoriatic arthritis, and there are features of the disease activity that are not counted in a 28 joint count, such as foot involvement, dactylitis, DIP involvement, and skin and nail changes. Psoriatic arthritis can be aggressive and result in damage and functional impairment. There can be a poor quality of life and cardiovascular morbidity. We have had great success running real-world trials in Canada, such as CAMEO, which was an RA trial with etanercept, and the optimization study, which was an adalimumab trial in rheumatoid arthritis. It's assumed that treating to a target will allow patients with psoriatic arthritis to improve more quickly or reach a low DOS more quickly than usual care. No randomized controlled trials yet have demonstrated that more patients with psoriatic arthritis, or PsA, have reached the low disease state if therapy is targeted compared to routine care. One trial in the UK has a Tacora-like trial in psoriatic arthritis, which is currently underway. The purpose of this study is to have a randomized controlled trial to determine if more patients with psoriatic arthritis achieve a low disease state, as measured by a DOS less than 2.6, in the care of rheumatologists who treat to a target compared to those who are given usual care. Other features will be studied that are unique to psoriatic arthritis, such as dactylitis, enthesitis, skin involvement, and nail involvement. The primary outcome is to compare the proportion or percent of patients meeting a DOS 28 less than 2.6, comparing between intensive care patients and routine care patients. Secondary outcomes include comparing the time to DOS 28 achieving a low DOS 28, the ACR 20, 50, and 70 responses, the PsA response criteria, or SARC criteria, and to compare the HAQ, or Health Assessment Questionnaire Disability Index. Inclusion criteria are psoriatic arthritis as diagnosed by a rheumatologist meeting the ACR classification criteria for psoriatic arthritis and/or the CASPR criteria. The subject must provide written, informed consent for participation in the study before any study-specific procedures are performed. A subject must have 3 or more swollen joints on a 28 joint count. I'll remind you this does not include the DIPs. They have to be adults aged 18 years of age or older. Exclusion criteria include the subject has a history of being non-compliant or a serious concomitant illness. If you're going to be treating with a TNF inhibitor, usual testing with the PPD skin test is important, and if it's greater than 5 millimeters and the patient hasn't received INH, it's a recommended course of INH prophylaxis. A chest x-ray has to be performed to rule out latent TB infection. Usual screening is in place for standard of care. Pregnancy, breastfeeding, or considering pregnancy over the next 12 months would not allow someone in this study. To remind you, the doctor is randomized, so this is a cluster randomization. All the patients will be in the same randomization block for each doctor. What about the treatment? Access to all medications will be through usual care. At any visit, steroids given intra-articular, IM, or oral are allowed. Optimizing DMARDs such as methotrexate, adding, increasing the dose, switching to parenteral are all allowed. Adding other medications or switching such as leflunomide, sulfasalazine, or other DMARDs are allowed. Adding a TNF inhibitor is allowed, such as etanercept. Optimizing treatment by adjusting DMARDs, including new DMARDs, is allowed at any time. Switching to another TNF inhibitor or switching to other agents are allowed at any step along the way of intensifying treatment. All patients will have standard of care, and they will have more specific treat to target care if they're in the treat to target physician group. Study visits. The baseline visit, you'll enroll the patient, informed consent will be signed. Follow-up is mandated at 3, 6, and 9 months. Any other visits are at the discretion of the physician. You can enroll as many patients as you want. All good clinical practice is to be followed. Serious adverse events will be reported. This trial is registered. Good luck. If you have any questions, please contact me, Dr. Janet Pope, at 519-646-6332 or my fax, 519-646-6334. If you are targeting treat to target cluster, then I'm going to tell you some more study-specific procedures. If you are treating to a target in that group, this is cluster randomization, so all the patients will be in the same randomization for each doctor. You're trying to treat to a DAS of less than 2.6. If it is not achieved, you are to make a change in treatment. This can be injecting a joint, changing or adding DMARDs, biologics, steroids, etc. If you don't treat to a target, and you are supposed to, you need to give the reason why, i.e., the patient is not yet in a steady state, they're already a lot better, or other reasons. You may get a query about why you are not achieving the target of a DOS-28 less than 2.6. You will need to calculate the DOS-28 at each visit, and you will be provided with a website to input the data and calculate the DOS-28 score.